Okay, good. So good morning, everyone. We will call this meeting to order and we'll start with the roll call. Mary?
Sue Patterson.
Present.
Alan Barfoot.
He dropped off and dropped back on. There he is.
Alan Barfoot.
Present.
Brian Milne.
Present.
Brian O'Leary.
Present.
Chris Peabody.
Present.
Luke Charbonneau.
Here.
Selwyn Hicks. Helen Claire Tingling.
Good morning to you, Mary.
Janice Jackson.
Here.
Nick Saunders. Nick Saunders.
Okay, thanks, Mary. Nick is on the line. Selwyn will join us.
Sorry, I got it. I'm here.
Thanks, Nick. Hello. Selwyn, I'm sure will join us when he's available. And I would like to welcome Luke Charbonneau, who is the mayor of Saugeen Shores and is one of our Bruce County representatives. Hello, Luke, and welcome to the board.
Thank you, Madam Chair. Good morning, everyone.
Good. Okay, so with the agenda, are there any amendments to the agenda? Not at this time. We will be changing the closed session timing to 10:30, if everyone's okay with that. So I need a motion for approval of the agenda. And if I don't see you, just please speak up, okay? Alan moves it, and Brian O'Leary, second. All in favor? That is carried, thank you. Does anyone have a disclosure of pecuniary interest or a conflict of interest? Seeing none, thank you. If one should arise during the meeting, you may declare it then. Item 5.1 is the regular meeting minutes from November 26th. I need a mover and seconder to adopt those minutes. I have Chris Peabody and Brian Millen. Is there any discussion with those minutes? All in favor? That is carried. Thank you. Item 5.2 is the Board of Health Executive Committee meeting minutes from December 6th. Again, a mover and seconder, Alan Barfoot and Helen Claire. Any discussion? All in favor? That is carried. Thank you. And Nick, very nice. We have Santa in the room with us. Well done. All right, so we will move on to correspondence and news releases. Dr. Ayres.
Thank you, Madam Chair. The correspondence from the past months has been only one correspondence letter as the board directed to highlight the support that Chapman's ice cream provided to the community throughout the pandemic, and that was done, and we CC'd the board on it for notice for inclusion. Would you like me to go to the news releases?
Yes, please.
Thank you. Over the past months, we had a number of media releases, 18. The highlight of them, I would say, 2 media releases. One of them is number 11, and the message there for people to stay home if sick. And this recommendation, or this strong recommendation, is based on the underlying denominator among the cases we've investigated over the past months, where people who had symptoms continued to go to work or to activities, or sometimes to go to school. And that generated a number of high-risk contacts and cases. And that's where the recommendation has been. And this still stands here. And we strongly recommend to the public to pay attention to this. And we've seen the response to this messaging, Madam Chair. The second highlight, I would say the number 14, there has been a number of schools, two schools or so, two schools, one of them completely moved online learning, the other one partially. And that was not under public health direction. It seems that with the news about Omicron and the provincial and national media, that created some confusion in the public, whether public health directed it or not. And we issued a number of communications to reassure the public that if we ordered the closure of any activity, we would be the people posting it and communicating about it. And the reasons for not jumping to closure of school is the fact that we follow the protocols and follow the science. In the MOH update, there will be more information on the situation itself and how it was deciphered, whether the transmission is happening in school, in a class, or in school, in organized sport, or in sports outside, or in activities related to them. And now we have the luxury of looking back at that time. The fact that we did not order closure of school was the right decision. The transmission was not happening within class, definitely. Those are the highlights from the updates, Madam Chair, and open to questions as always.
Thank you, Dr. Ayres. Are there any questions or comments regarding the correspondence or the news releases? Helen Clare.
Yes, thank you. Through you, Madam Chair, just a comment and seeking a little clarity on the last item, item 14. Am I to understand that these closures are happening under education legislation? So I'm not familiar with the Education Act as I am the Health Act. So it sounds like there is some discretion in there for educators or administrators rather to close schools if they feel so inclined, which obviously in attacks or lockdowns and that kind of thing would need to happen. I would just be interested in hearing from Dr. Ayres, Madam Chair, if that is the case, if it's under the Education Act, since what I'm understanding from Dr. Ayres is it's not to do with public health at all. Thank you.
Thank you, Dr. Ayres.
Thank you for this question. The direction to close the school or the classes was based on the school board decision. My understanding it's not directed from the province, but it's allowed through their ability to operate the school. And the underlying reason to it, to my understanding, again, I can't speak for them, but that's my understanding from meeting with them, that it's much easier to open virtual online learning whenever there are cohorts dismissed. So in these schools where there was a number of cohorts, and one of them is 2, and one of them at the time, I believe it was around 7, and the ability to provide virtual learning to those cohorts and in-person learning in school would require more human resources around the holiday season might be limited to that. So it was more or less, again, a management decision from the school board, not based on a high level of risk that warrants closure of school.
Helen Clare.
Thank you. Follow-up question, Madam Chair. I completely understand how difficult it must be for the school boards to keep having to boomerang back under these situations. Dr. Ayres indicated that he had a conversation with them subsequent to the closing, and I'm wondering if it's possible to encourage them whenever they take such an action to communicate clearly that it is the school board decision and why, in the same way that public health, when closures happen, communicates clearly that it is a public health decision. and the reasons why that is outbreak, because it seems from what I'm understanding and reading in the community that people are presuming that any closure by default is public health, and then there's tends to be some blowback about that. Thank you, Madam Chair.
Thanks, Helen Claire. Dr. Ayres?
Thank you, Helen Claire, for that. Just to be complete there, in the communication with the school board, there is communication before the closure. In most of the cases, I would say there is robust communication. The second point, it's definitely a valid point that if we can increase the communication on who made the closure. In one of the cases, we had a joint release, and another one we didn't. But it is really important to point out that there is a lot of anxiety related mainly to the hardship of the pandemic and the fatigue. So I suspect the school might have had communication. Can we increase communication in emergency? Too much communication is not enough. And that I would echo definitely your point that that might help in reducing the confusion and the anxiety.
Thank you, Dr. Ayres. Are there, Brian OLeary?
Thanks, Madam Chair. Just in addition to this, I'm just wondering, Dr. Ayres, if there's it may not be an answer to this. Is there a different way that we can do our media releases and send a message right away that people don't need to try and be proactive on their own? Because I think that's what's happening. And a perfect example is, you know, as soon as our media release went out that there was a hockey team involved, right away, minor hockey groups got together and wanted to start making changes in the name of being proactive. And I think, you know, there's half the people are going, well, did Dr. Ayres order this, or are you doing this on your own, or why are we doing this on our own? And it almost starts a panic in different departments and different interests. And I'm just wondering if we can say right from the get-go, this doesn't mean that organizations need to start being proactive. We will monitor and that sort of thing, but I'm not sure if we could do that.
Thank you. Dr. Ayres?
Definitely a good point, Brian. You look at the management of the pandemic. If we zoom out, the bulk of the work is in communication and management of two things. The level of risk, if I'm looking at XY axes, the X1 is the actual level of risk. People need to know what's risky so they can respond, and we provide recommendation to address that risk. The other axis, which is 50% of the work and sometimes more, is the technical term is outrage or anxiety management. We do our best to map out where people act, and you're right, different entities being proactive or an intention of being proactive can, in their actions, create anxiety that would require management on its own. Since day one, or even before the pandemic started, we highlighted that the agency that's taking the lead of the pandemic is public health. And we use the analogy of if there is any incidents require the police or the fire department to be involved, everybody knows who's the agency that they need to respond to or support. And despite that, and over 20 months, we can see that the anxiety sometimes might get the best of people. And of course, it's under the good intentions to do more and to be proactive. It's a very good point. It is very, very tricky point, especially after 20 months of fatigue.
Thank you. Luke?
Yeah, thank you, Madam Chair. And I just wanted to support what Brian is saying there. And actually, it goes to one of the other releases that's in the list, number 16, increase in COVID-19 cases, trends and precautions. And if you look at that release, and it was a concerning release to me, and I'd be interested in hearing Dr. Ayres' comments, because in the release, public health talks about restrictions that may occur sometime in the future. around sporting. We may pause sporting events, may end travel of minor, may pause sporting events within Grey Bruce altogether. And I think when we talk about provoking fear and provoking the kind of reaction that Brian talked about there, that's, you know, I'd be interested to know the thinking behind a release like that, because, you know, to me, it seems like we might be better off to save our releases for when we're actually going to take a step, rather than projecting forward about steps we may take sometime in the future, because then that leads sporting teams and things to react the way Brian just laid out there, to jump to the nth degree and to say public health. They don't read the may, they say this is what should happen, and then they start to do it, and that may be good, but it may also not be good, because there's a huge downside impact from a public health standpoint to pausing sporting events across Grey Bruce and doing other things like that. So do you think, Dr. Ayres, that do you think that I mean, what do you think about that, I guess, is my question. And then maybe as a corollary to that, the release you put out yesterday, which I thought was a fairly good release about sporting events, almost seems to sort of walk back the concern that was in this release, and say, well, it's not as big a concern, and we can still do sporting events with these particular caveats. So what do you think about that trend, about that process and communication? And do you think that maybe we should be more clear about what the restrictions are when we're making them, rather than thinking about or telling the public what we might do sometime in the future?
Thanks, Luke. Dr. Ayres?
Thank you for this great question. I really appreciate this discussion. So the reason number 16 was issued is exactly to reassure the public of to address outrage in the local community, especially around Own Sound, about the fact that, one, the school was closed and the perception it is public health that closed it. Two, to address the high level of cases, and mainly the third one, to address the anxiety in the majority of the public who are out there to say you need to shut down all sports. So there is a notion that there is Omicron that the health unit did not put forward information about. There is a notion that the provincial messaging is indicating very high risk, that we need to close many activities, and that the health unit is not doing us so. So we needed to outline that we are ready to do 1, 2, 3, 4, but we need to wait for the evidence. We cannot really decipher if the transmission happened in school, happened in hockey, or in other sports, and sports within the school or outside of the schools. Those are the three categories actually that are going to come in the update, but I'll be more than happy to go through them right now. So when the number 16, the trends and precautions were issued, we did not have the granularity to distinguish, is this transmission within school or sport events in the school or sport events outside of school. And the reason is the number of cases that are in the school, students who play on the school team and play outside the school team. So we needed more information, more data, more cases that will surface from the transmission. And if we do proactive or robust testing, mass testing on Monday, which we did, we will get the number of cases that we did yesterday on our SIT report, 32. And it distinguishes that the majority of cases were on a sport team in one of the sports, specifically basketball, not hockey. And if you look closer, within the class, there was no transmission. And one example is the large school, 1,000+ students, there was no transmission within a class. That is very reassuring. With the hockey externally, it's part of the team that plays in the school actually plays hockey, but it was way less numbers in that bigger hockey team. So that's another evidence that their transmission did not happen in the hockey team externally. Then you look even closer at the cases themselves. they are teammates, and we know teammates at that age, they are buddies, they are friends. They have sleepover, they have parties, they have carpooling, and those activities are most likely, not most likely, probably, almost definitely where the transmission happened. You look at the exception to all organized sports that we looked at from the examples we have, and there are not many. Basketball is the exception where the transmission might have happened within the game. It is high contact game. Individuals sometimes are defending against certain positions and in face-to-face for a period of time. So if you go back to the day that number 16, the trends was issued, none of this information was available. And to be complete and frank, as always, with the public, especially in the light of many individuals in the community on social media and reports from local community leaders that there is something brewing, that the health unit is not providing information, not doing enough. We needed to put that. So it might not be the same situation in different part of Grey Bruce where that was not impacted, but in Owen Sound, in the catchment area to it for school and other activity, it was necessity. Otherwise, we would have lost credibility. And we had to wait 2 days or 3 until we get the data. And as you know, Mayor, during that time, I had consultation with leaders in the sport, whether from Kincardine, Owen Sound, or yourself as a leader of organized sport. So it has to be done based on evidence and has to take its time, and we have to be responsive to the anxiety in the public and the outrage is technical term. It was not outrage in a way that people are acting on their anxiety, but it was completely responsive. And I look back, I would not change actually anything in the sequence of event, so long that we are following data and evidence. We can stand by it and say this is the way it was done. There will be a bit more communication on this as we get more cases, and we will expect less cases than 30, but still we have high number of high risk contacts. So we will get more robust picture, but with the picture we have, I feel very confident this is where the transmission happened. I hope that addressed the question and why we issued the release.
Thank you, Dr. Ayres. Any further comments or questions? Helen Claire and then Chris.
Thank you, Madam Chair, through you. Just to build on this social media fanning of flames that we're, as a board and as a health unit, having to walk alongside all the time. There is the competing narrative, but I don't think I subscribe to the idea that competing narrative is usually out of fear, out of anxiety, out of frustration, out of the desire to do something, and the fear that public health doesn't have a handle on it. And of course, that's a lot to do with what's out in the media, and again, competing narratives. I did find it interesting to follow the analogy of police. And I believe that if everybody was armed with a gun, we would see a parallel where if people don't think the police are doing their job, they would pull out guns and deal with things. And it would be a similar kind of scenario to what we're seeing here, although less dramatic. And what I mean by that is people that feel public health isn't doing anything and they read things and they get anxious, they take matters into their own hands. There's no doubt that good intentions are there, and it just seems to be a disconnect between the good intentions and what they need to do. And what they need to do is, of course, what is communicated in public health. And I do believe that public health is doing its best with media releases and communicating in a variety of ways. And I just, at the risk of dangerously treading on an operational issue, and I certainly will accept if this question is not appropriate, but just wondering, because there is quite a bit in what's coming up about outreach and engagement, and that is a big part of public health. Could we go further with that outreach? In other words, when this kind kind of thing that we're hearing from my honorable colleagues, Brian and Luke, about the impact that they are seeing in sports. Would it be appropriate? Is it possible for members of the outreach team to contact those leaders and say, no, I'm understanding that this is happening. We're all looking at the transmission that's happening in sports. These are the things that you could do. I know that you want to do something. I'm aware this stuff is on the websites. I'm aware that it's there in media, but maybe that one extra step of a human being, sometimes one-way communication that happens in media releases can't be picked up by people in a way that a conversation can. So again, Madam Chair, I accept if my question is not appropriate, and I will withdraw it. But if it is, I wonder if Dr. Ayres' team could consider perhaps that extra level of outreach in times when we're hitting spikes and trends. Thank you, Madam Chair.
Thank you, Helen Claire. Dr. Ayres?
Thank you for another good question. We do have connection with the organizations, and depending on the sector, we do outreach. For example, yesterday's media release was consulted on by and data was consulted on by 3 leaders from the organized sports that this is coming, and of course that's gonna have it's gonna address part of the anxiety in certain teams, and depending on the connection of these leaders with other part of the sector. But you can appreciate the main outrage or the main anxiety that was responded to is the fact that many people saying you need to shut down all schools around the weekend time. Last weekend, there was messaging, their anxiety in the community, not from the sports, rather from the general public, that the schools are not safe, the hockey is not safe, you need to do all these things. So unless you address those in a timely fashion, and we do our best to communicate with people, but most people are not there waiting for public health to say, what is your next step and how we can consult on it. I sent an email, I believe on Monday, I got a response about it on Wednesday, which is great response time. And I can't ask people to be more engaged than this. This is as excellent as it gets. And if we can remember something there is a tremendous amount of messaging from the provincial and national level about the Omicron and about the risk and about what's coming and the need to shut down sectors. Other health units have either moved or contemplating moving to orders, Section 22 or letters of instructions. In Grey Bruce, we have managed without any of these tools. The compliance from the public has been optimal. Anytime we're dealing with communication to the public and response of 50–60%, it's a good day in public health. In Grey Bruce, we have managed to get over 80 and 90% depending on the intervention. So you put all these things in perspective. Yes, the hockey sector is a very important sector, and we don't want to reduce the chances for young adults and their families to be engaged in a sport that is providing well-being. But at the same time, if you find the rest of the public, or sometimes the same family split in two, wondering why you did not take actions following the province or the country or other health units. And we know that data is suggestive of association with hockey. There is no way not to communicate in a timely fashion. And we've left it 2–3 days until these sector leaders responded, and we managed it in a way that everybody's on the same page. Practically, it's just not going to happen, because 3–4 days, the other group is going to be up in arms and lose trust in the health unit. And if we do it as fast as we did it, with some consultation and with some conditions that we're looking into it, and we're not taking actions like other health unit has already taken action, that's the happy medium that we assessed and we went ahead with. Again, I look back, I don't believe there was something else we could have done to get better results than we had so far.
Thank you, Dr. Ayres. Chris?
Yes, I'm running my audio off my cell phone, so I just hope. Can you hear me there?
Yes.
Yeah.
Yes.
Okay. I got some technical difficulties. I got my computer laptop on too. Yes, Doctor. I think I'd just like to compliment your staff on the Owen Sound communication. Watching the situation from Walkerton, I thought the communication on what was going on with St. Mary's was excellent. All your press releases, definitely, I was able to follow them, and I thought it was very good work. The Holland Chatsworth thing, I think things got a bit muddled there, where there was a work refusal by the teachers, but that people need to know that wouldn't be our jurisdiction because it's inside the school walls. It's Ministry of Labor, but things seem to that one seemed to get a bit muddled in the media with the teachers doing the work refusal and what was going on up there. But I don't think it would be attributable to health unit. St. Mary's situation, excellent. Now that Drew's gone, who's handling our media stuff for us?
Aaron?
Thank you for the question. That's a management question. And if you recall, early in the pandemic, we identified certain positions that need redundancy to ensure if a person is not there, somebody will do their job. And if somebody's, needing to take their time off, it is taken care of. One of these positions was the media coordinator. And we had another manager doing the mirror image of everything that the media coordinator does, with a number of 8 health promoters who have training in marketing. Marketing usually healthy behavior, good healthy behavior, but nevertheless they have been, depending on the time of the emergency, whether it's a wave or recovery, 4 to 8 of them are involved in the media team to monitor the social media, to monitor the media, to produce documents, hundreds of documents a week, whether it's internal or external. You can see that we had 18 media releases, just an indicator of our ability to respond to whenever needed. Thank you for the question.
Thank you, Dr. Ayres. Anything further? All right, that was a good discussion. Thank you. We need a mover and seconder to approve the correspondence and news releases as presented. Brian O'Leary and Alan Barfoot. All in favor? That is carried. Thank you. So we will move into the in-camera now. So back on the agenda at item 6. Has been recommended that the Board of Health meet in closed session in order to address matters pertaining to advice that is subject to solicitor-client privilege and also security of the property of the Grey Bruce Health Unit. I need a mover and seconder to move into closed session. Selwyn and Luke, all in favor? That's carried. Thank you. Just give us a second for Mary to make sure we're in camera. Or Kaylee.
Madam Chair, just a heads up, I have to leave here in about 10 minutes.
Thank you.
I do also, Madam Chair.
Okay. All right, welcome back. We are now in open session, and I declare we only discussed the items that were on the closed meeting agenda. Moving on with our agenda, we have a staff presentation, and I don't see Ian right now. So Okay, so Ian Reich, I'm sorry, Ian, apologies if I did not pronounce your name correctly, but Ian is going to speak to us about foundational standards.
Hello, everyone. Thank you so much for having me today. I'll just work to share my screen here with the presentation and we will get started. All right, thank you so much. So obviously the title of the presentation is Foundational Standards, and we'll talk about what they specifically are, as well as who we are as a team. I'll be happy to introduce the team. So just to start, I'll go through a general outline of the presentation, which we will cover off strategic direction and operational plans and how they sort of work together and coincide, who we are as a foundational standards team, and what specifically are foundational standards. We'll cover things like how does the foundational standards team operate, areas of priority specifically from the Ontario Public Health Standards, such as project management support, development and matrix structure for each project or area of priority, program evaluation, knowledge and translation, population health data support, and also in-depth program needs assessments that we are completing this year and next. So in terms of strategy versus operation, it's really important that us as an organization understand that they're very, very different. However, they each really do relate to each other significantly. So the strategic plan really does allow us to achieve what our mission, visions, and values are as an organization. It really helps guide us, our behavior, expectations, and culture as an organization. And it gives us coherence and an understanding of how we need to develop an operational plan. What our operation plan is, and I see it as the strategic goals, mission, vision, and value are the pieces of the puzzle that need to be put together. What the operational plan does is actually put those pieces together in a coherent image, I guess you can say. Just to give everyone a general vision or visual of what foundational standards really should be. Obviously, a really strong foundation is critical to building a house or any type of structure. And that is what we view our our foundational standards team as being, really setting that strong foundation and providing all of our teams within the organization with everything that they require from data, evaluation, and equity support to ensure that those programs can be designed on a firm foundation. And this just really shows how us holding that structure up really does hold the entire program standards from the province up in our different program areas of program priority, from emergency preparedness, environmental health, infectious disease, and more. So again, a strong foundation really does help ensure that all of our programs can operate as best as they possibly can. So to start, our foundational standards are from the Ontario Public Health Standards, and really they're broken into multiple categories. So the first category that I'll just touch on very briefly is our population health assessment category within the Ontario Public Health Standard of foundational standards, sorry. So the goal of this practice is to respond effectively to current and evolving conditions and contribute to public health and the well-being of the public with programs and services that are informed by the population's health status, including social determinants of health and health inequities. So that's the goal specifically listed in the Ontario Public Health Standards. And within that, there's very specific program outcomes that standards asks us to do. From being aware and using data to inform and develop local plans, also in the planning and delivery of all of our public health programs and services as well. I won't go through them all, they are quite extensive. However, I just wanted to highlight the importance of what this category in the foundational standards really does entail for our work. And it really helps drive an efficient and effective annual service plan, or in other words, our operations plan. Moving on to the next section is a section called health equity. And obviously, this is a critical component of a foundational standards team because we need to ensure that we're addressing all inequities within the services that we provide in Grey and Bruce. And in order to do that, we have many tools at our However, our nurse is really going to be focusing on specifically health equity impact assessments for each team as they develop their annual service plan, as well as our areas of priority. They will be an integral member and part of those teams to ensure that health equity is always addressed in the areas of priority and in the programs that we operate. From an Ontario public health standpoint, the real main goal of this is to decrease health inequities such that everyone has an equal opportunity for optimal health and can attain their full health potential without disadvantage due to social positions or other socially determined circumstances. Moving on into the next category, it actually has 3 sections within this category, is effective public health practice. And those 3 sections are program planning and evaluation, evidence-informed decision-making, research, knowledge exchange and communication, quality and transparency as well. So those 3, I'll call them pillars of this, are critical. And the overarching goal of this section of the standard is that we will be transparent and responsive to current and emerging evidence and emphasize continuous quality improvement. So again, these will be an integral part of all of our areas of priority and our programs moving forward. To continue in that section, each area of priority obviously will be managed based on this section or this team within our Ontario Public Health Standard. We will be identifying, based on our strategic vision, we will be identifying certain areas of priority that we as an organization really want to focus on in the coming years, from short to long-term goals, 1, 3, 5-year type goals. So each area of priority is going to be broken out into what we call a project management. So we will have a project coordinator or project lead that will ensure that each area of priority is managed in a project management style to ensure that it's always kept on track. So the foundational standards team obviously will review all the priorities, the provincial standards, the protocols, and the guidelines, and will build the project team to ensure that every component or every program within the health unit is a part of this project team if they have a vested interest as per their public health standard or guidelines or their protocols. We will be able to share not just program planning and evaluation, but also we will be able to give them as much evidence and data to support and inform decision-making as we develop these projects in these areas of priority. We'll also be able to help with research and knowledge exchange, and of course, communication. So our team will, this team here is again going to be called more of a project team, and we will be designed in a matrix style. As I explained, we will intersect every single Ontario Public Health Standard, guideline, and protocol and capture each team that has a vested interest in this area of priority and involve them in this project team together. And that's really what a matrix design is multiple teams working together towards a common goal. And then we get to our effective public health practice. I'll continue on. So as we work through the projects, we will, to start the project itself, we need to identify it first. And then from there, what we want to do is really develop what's called the logic model. This is a very high level look down upon this project to really understand what the main goals are, what the main pieces of data we need to collect and observe and evaluate to ensure that that is effective. And then also within this, we assign areas of responsibility using, I'll get into it in the next slide, the RASI model of accountability and communication, and I'll review that in detail. But once we have our overarching high level logic model, we then break down each component of that logic model into specific work plans that will look specifically at roles, responsibilities, and accountabilities. We'll have very clear matrix management structure. Everyone will know exactly who they are and who all the members of the team are, as well as what they're doing and who they're working with. Each project will also have a built-in evaluation framework that is, again, based on our goals and objectives for the project, as well as health equity impact assessment as described earlier. That needs to be a main component of all projects that we do. Along with that is also going to be a needs assessment or gap analysis to say what's missing, what don't we have, and how can we fill in those gaps. And then at the same point in time, for each of these different projects, we'll have different and innovative ways to communicate what we are doing to the appropriate stakeholders, community partners, as well as internal staff. So just to describe what I mean by the RASI model, this is an accountability framework that really highlights and points out exactly who's responsible, who's accountable, who needs to be supportive, who needs to be consulted, and who needs to be informed. For each work plan that we develop within our logic models for the projects, they will have an assigned RASI matrix to it. So every single person on that team, internal and external stakeholders alike, will understand exactly what their roles are and who needs to be informed at all times. Also, another portfolio as we move past the project management is emergency management. So we currently do have a really good emergency management plan here at the health unit. However, we really want to take a close look at that and see how we can make sure that we're not only able to respond to emergencies, but provide as much input as possible to help prevent emergencies. So that work will be definitely a focus of ours in 2022. And then last but not least is our infection prevention and control nurses. So again, I mentioned they're not necessarily an official member of the foundational standards from an Ontario standpoint, but they're definitely a critical member of our team here. They are critical to ensure that there's robust data and on the ground quantitative input, obviously to align and make sure that each of our programs are also not just taking an equity approach, but also having a lens and a view on infection control practices should it pertain to their program as well. If anyone does want any more information about the IPAC program or the IPAC hub itself, I've just listed a few websites here as well that will be available in the presentation also. Just a quick little recap of what's next. So we as a foundational standards team, we will be developing an entire education series for the staff. We started off with this quick presentation, and we will also then embed an orientation package for all new staff as well, so that they really understand who we are and what each component of the foundational standards does. We will develop a detailed matrix design for our organization based on the projects that we choose, and then also based on how we work together on an annual function as well. There'll be detailed information about each main section of the foundational standards team as well. And then also we'll continue our education series to make sure that we understand and that our organization fully understands how we are going to be working together throughout the coming year. So I did go through that rather quickly and briefly, but I did want to give just everyone a high level overview of who we are as a team and what our main goals are going to be throughout the coming year. So happy to address any questions should we have any, and we can go from there.
Okay, thanks, Ian. That was a very good presentation. You can see how all the plans are going to interact and the basis of promoting health and helping staff to do their job. So thank you very much for that overview. Does anyone have any questions or comments for Ian? A lot of detail there, a lot of information. So I don't see any questions, but Ian, thank you very much. It's appreciated to see all the work that's been put into that and how things are going to move forward. So thank you, Ian.
Thank you so much. Take care, everyone. Happy holidays.
And you too. Okay, next on the agenda is the update from the Medical Officer of Health, Dr. Ayres.
Thank you, Madam Chair. So the update on the COVID situation is very similar to the discussion we had over the correspondence. Locally, we have seen a change in the trends that we had over the past couple of months. Over the past 10 days, we've seen increase in the number of cases, and the sharpness of the increase reflects the transmissibility of the variants, whether it's the Delta variant that's still circulating or the potential Omicron that we have not received confirmation yet. We call the lab on daily basis, but it seems these tests take time and there's quite a demand there. Nevertheless, we're taking no chance and we're treating every case with the stringent measures, enhanced measures of case management that's required for Omicron. And we actually started this last Friday before the provincial direction that came this week to do so. The number of cases have increased, and over the past weekend, we've seen number of cases in younger individuals attending school and attending organized sports within the school and attending organized sports outside of school. The cases in general started a chain of transmission in their contacts, family members and friends. So the majority of the cases are not people in the sport, rather that's where the initiation of the transmission. We asked for testing for cohorts, different cohorts from school, and one school, as I mentioned, is over 1,000 students. We decided to test the entire school based on the number of cases and the fact that we don't know if the transmission is within a school or within the sports. The testing locally, access to testing is not available over the weekend at the assessment centers. And we have worked with the partners, whether it's the hospitals or communication to primary care, to encourage increasing that testing. But the window of time required to identify cases and their potential exposed close contacts required us to deploy our staff to do testing. And we opened 3 days of clinics at the health unit. The first day we tested over 300 cases or 300 individuals. The assessment center, some of the primary care, the Peninsula Family Health team was very responsive, starting testing, and we commend them on that effort. The results came over the past 2 days with 32 positive cases that allowed us to map out where the transmission is. And with high level of confidence, the class environment in schools, in that specific school, but it is generalizable to the rest of the Grey Bruce school system, had, in that specific example, there was no transmission. In general, in Grey Bruce, the transmission is very minimal. It's a handful of cases, including the Chatsworth situation. There were transmission to 3 individuals within the school, and there were a total of, I believe, if my memory serves me right, around 13 in total. So 9, the transmission happened in the community, and you can appreciate there are families who have 3 or number of kids that attend the school, and the siblings are infected, but their classmates are not. So that's the school environment, or sorry, the class environment. In the organized sport within schools, we've found that there are 2 sources of potential transmission. One in sports that has face-to-face contact, like basketball specifically, and in the social events that precede the game or after the game, carpooling, and whether it is social gatherings or the some of the activities where the teammates are spending time as friends, not as on the ice or on the court. And the final part of that set of data that was looked at is the hockey activities. There has not been locally been any evidence that the transmission happens on the ice. Rather, again, similar to the previous organized sports in general, in the socialization among teammates. The tournament outside of Grey Bruce is a higher risk, and I can't speak to what happens on the ice or in different parts of the organized sport, but in general, there is evidence of transmission for our players who played in certain hotspots. So that is a local situation. If we zoom out and look at the provincial situation and recommendation from Science Table, they're obviously describing worrisome, concerning, alarming picture of the Omicron, the new variant, becoming last number of 30 or 40% of cases, new cases in Ontario, which is quite alarming. The evidence, early evidence shows that the variant is not as severe But again, that's from a population in South Africa that is younger in age, and they might have had previous exposure to different variants, or that they might have different characteristics in the population here. The transmissibility seems to be higher, fourfold higher than Delta, considering that the vaccine efficacy might be less with 2 doses. And there is recommendation from the science table for a 3rd dose as soon as possible. Regardless of the details of the scientific data that we have not reviewed and is not, still the research is providing that complete picture about characteristics of the variant and epidemiology. Regardless of all those, there is a fact that always stands. A 3rd dose of any vaccine will boost the immunity more than 2 doses. And that is a solid practical next step, whether it's based on the local events or based on the provincial direction to start mass immunization. And that is our plan for the coming weeks. There's a question always, how soon can we start this? And we have our clinics in the community, in the 19 community centers, already booked and filled. And we have our staff, every single staff who can give vaccine is out there assigned to these clinics and doing vaccines on a daily basis. It will be prohibitive to start mass immunization next week, although we are starting to work with we're working with the task force for Bruce Power specifically to set up the mass immunization, and the first one will be set up next week. We're going to utilize staff from Bruce Power with support, not minimal support, but the required support from our staff for cold chain, for COVAX, which is a registration for a patient, for inspection of IPAC of these clinics and location and setting them up. And that will be next week, and the details are still coming. That will be the first clinic, but we cannot ramp up mass immunization until January, when we already have completed our duty to provide these clinics. Considering if theoretically would consider canceling the smaller clinics in the community or rural communities or across Grey Bruce and opening mass immunization, practically we can increase the numbers, but it is an extreme reputational risk and hit to the trust that the public has in the health unit. So from those point of views, the ramping up of mass immunization will start January 5th. Depending on the number of people eligible, depending on the number of people who can be given the vaccine in these mass immunization, and we're planning to open 3 of them and operate 2 on a daily basis, we can provide the vaccine to around 6,000, 7,000 per day. So we can complete the eligible population in a matter of 3 to 4 weeks if everybody comes forward and wants the vaccine. But we know that the eligibility requires 6 months or 3 months, depending on the direction. NACI, the science says go 6 months between the 2nd and the 3rd one, and that's going to provide a stronger, long-lasting immunity versus the provincial direction to shorten it to 3 months to give it to more people, but the immunity will be less. Again, the operations of it is going to show how this is going to pan out. We're prepared for both scenarios, and it might be extended based on that eligibility period to give the mass immunization in January and in February. Practically, we can finish the job in the shortest period possible. And I have high level of confidence, like we delivered over the summer in Grey Bruce, over 50% around 50% of our population, eligible population, within 3 to 4 weeks in July. I have the same level of confidence and more. If I can finish that update, Madam Chair, with the notion of communication about this, the provincial communication is obviously alarming and driving a lot of anxiety in the public. driving a lot of concern, which would be great, but there is also the anxiety. And the anxiety comes from two sources, like I mentioned. One is the people who wanted more measures immediately, and obviously the anxiety from people who are tired and fatigued and might not comply if there are measures that are directive or based on orders, emergency orders or Section 22 from MOH orders. In general, when we look at the past 20 months in the emergency in Grey Bruce, we have witnessed optimal compliance from the public, and there is clear indications from connecting with different partners, and we already evaluate this as we go. Things change quite rapidly, but at this point, if you put an order to people who are already compliant or compliant to the best of their ability, it might backfire and we might lose part of that compliance. And the data that we've seen, it shows the increase that we predicted. Today, last time I looked at the number of cases before the meeting, there were 2 cases, which is very consistent with an end of day that could be around 10 to 15, which is less than the 20 we received yesterday, or 22, less than the 32 the day before. By next Wednesday, if we're able to bring the numbers to a manageable number under 10, I will have more confidence to say this is, in essence, similar to the situation we experienced in July, where the science table said you're going to be overwhelmed in Grey Bruce for at least 12 weeks or more, being hotspots, similar to the experience in other areas that had Delta. And we, at the time, we decided, like always, to go with the hard data that we're experiencing and the dependence of the compliance in Grey Bruce and the robust case and contact tracing in-house. And we've managed to end that hotspot in 3 weeks. I'm cautiously optimistic that if we, by next Wednesday, are able to demonstrate the control over this surge, like the previous surge, we will be able to give Grey Bruce safe holidays, and have in the weeks after the ability to continue control. That's my update. I'm sure there are a few points that need more discussion. Open to questions as always.
Thank you, Dr. Ayres. Any questions for Dr. Ayres? Helen Claire.
Thank you, Madam Chair. Through you, no question, just a comment. I just wanted to take the opportunity to thank Dr. Ayres and everybody that works for the health unit. It's somewhat ironic to me that because of the increased demand on their services, we actually have to cancel this afternoon's event that would be a formal appreciation for them. And so I just wanted to acknowledge that dichotomy, that because of the extra push that is required of them, we're not able to even say thank you in an appropriate manner at this time of year. So, so I just wanted to express that. Thank you, Madam Chair.
Thank you. Alan?
Thanks, Madam Chair. Dr. Ayres, right now the number for indoor functions is at 25. Do you see that changing at all in the foreseeable future?
Through you, Madam Chair, it's very, very difficult to predict. We've seen locally how explosive the transmission is, and we're getting information from the science table that the new variant could be different from the Delta. So it's difficult to see what's going to happen in 2-3 weeks from now or past that. At the same time, the uncertainty is increased with the fact that the provincial science table and the provincial level might be moving with measures that, as you know, jurisdictionally, we cannot override. So we would have to go with locally in different parts of the province. Many MOHs are looking at dual approach, Section 22 orders and letter of instructions that might be implemented in an imminent future if the province didn't provide similar, and there's multiple discussions, rightly so, around this issue, like usual in pandemics or during the pandemic. So it's very difficult to see what's going to come next. But today, based on the data we have, I don't see the need to implement drastic measures. Asking people to be vigilant, the reassurance that the organized sport in-house within the game or the facilities is taken care of. There is quite a promise from sport leaders that the recommendation we're asking about socialization after the events and before the events are quite doable, and the younger individuals are most likely will honor the recommendation, because we all want them to continue to enjoy the well-being from participating in these games, specifically during these difficult times. But again, back to your question, if things changed in 3 weeks or 2 weeks or in January, we will reevaluate and we'll always follow these lines.
Thank you. Luke?
Thank you, Madam Chair. Yeah, and thanks, Dr. And I certainly echo what Helen Claire said about, in terms of thanks to you and your team for the work you've been doing. And every time we have one of these surges, it puts a huge strain on you and your staff, and we recognize that and thank you for it. I think you're right in your last comment there about how the community will respond just on their own with some clear advice from you, like I have seen in my own community in the last several days. Even though there has been no order, no direction to scale back on events around hockey or events around basketball, that people are doing that anyway, right? People are canceling team parties, people are canceling even ice times and things. People are stepping back, and I mean, I've heard, if I had $1 for every time I'd heard the term out of an abundance of caution in the last week, I would have a lot of money in my pocket right now. But I think that that's the effect that you intended to have, and that's good. I guess one concern that I'm hearing, excuse me, around the surge in cases that we've had in the last couple of weeks, a lot of people have received communications from public health saying that they should isolate and get tested. A lot of people in my community who I know, and so they're doing that. It's the get tested bit that's a real problem. People are having trouble getting access to testing, timely testing, and testing that's accessible to them, right? People are driving from Port Elgin to Lion's Head to get tests, right? Which is fine if you have a car and money to buy gas and time, but it's pretty hard for a lot of people. And so I just wonder, and I hope you're right, this Wednesday, maybe we see things level out and this isn't a big an issue, but if it doesn't, are you in a position to ramp up access to testing in a big way? Because I think it's in everybody's interest that we get these people tested in a timely manner quickly, so public health can assess them, so that they can get themselves isolated and everybody can be protected. And I feel like we have a gap there, and I'm just wondering if you have ways to ramp that up even further so that we can protect ourselves further on that front.
Thank you, Madam Chair. Thank you for this core question. Testing of COVID is not under the Health Unit Authority. Testing is, the health system has two parts. The healthcare system is the one responsible for clinical procedures, including testing. Public health is responsible for many functions, but testing is not one of them. We have deployed our staff to test, to be ready to test 1,000 people to fill in for that gap. One of the functions that we do related to potential testing or testing is to map out the need. And you're rightly so that there has been limited access depending on the location. This same issue took place, if I can give the example from the past, because it probably would reflect what would happen next, or it can provide, as an example, all the measures that could be done. September 2020, when the school opened, we realized that the 3 assessment centers we have in Grey Bruce which are under the hospital, and the hospital have stepped up to actually provide these centers, because usually the testing happens in primary care. and different areas of the healthcare system, but not usually the hospital. The province directed hospitals to do so, and they've done a good job. In September, with the school opening, and there was need for certain testing, but also there was testing driven by many factors other than the need. We realized that assessment centers did not provide us. So the health unit can provide the epidemiology work background for surveys and finding, is it testing for symptoms, testing for travel, testing because of anxiety, testing based on location. And we devised a survey over 3 weeks, provide the assessment center with guidance how much more they need to do so. There was interjurisdictional or organizational discrepancies where the province said test as, you have open testing versus Ontario Health, previously known as the LIN that manages hospital, implemented a cap for Grey Bruce, saying, if my memory is right, 650 tests per week, which is nothing. In that time, we meet with the hospital CEOs continuously and staff. And although it's outside of public health because it's an emergency, we have the authority to say we need to do this. But it was a discussion with the willing partners to say to Ontario Health, to that organization, that if you don't lift this cap, we are going to issue an order to say the hospital shall do this. And obviously, the outcome was positive. We were, by the end of September, to my knowledge, the only health unit that provided testing on the same day. So fast forward, over the past 2 months, we've noticed that there is a reduction in the capacity, and the hospitals have communicated this to us based on the favorable situation we have. And we ran a survey just to ensure that certain pockets of Grey Bruce require more testing. Obviously, the latest surge magnified that gap, and we have been in contact with the hospital assessment center, primary care pharmacies recently have been testing over the past few months. So that part, to the best of our ability, will guide the healthcare system. And there is no need that I see to use drastic measures like orders. They're always the least intrusive. And my understanding, the hospital's open Saturday now. There is potential for opening Sunday for one of the hospitals, and they extended their hours. Back to your question, if there is more need after a week from now, there is another layer to this. There is the discussion among OLeary's discussion with the ministry and the direction from the ministry that this might, the potential direction in the near future. If case contact tracing becomes overwhelmed in a way that the cases are extreme, the health unit will be directed to stop case and contact tracing and move to outbreak management only. So cases in the community, there's going to be a system provincially where they will register themselves and follow instructions that is already prescribed. A mechanical way to do case and contact tracing could be very suitable for that scenario, because the effort will be futile if you're going to call, let's say, 20% of the public versus one message to everybody. This is what you need to do, and this is the means electronically. I hope I answered your question about the testing management and the potential for the future changes.
Sure, thank you.
Okay, any further comments or questions for Dr. Ayres? All right, moving on, 7.2 and 7.3, Dr. Ayres.
The 7.2 still dormant, no change, and the 9.3, sorry. The opiate situation, no change from last update.
You are correct. 9.2 and 9.3, the modernization and opioid situation. So, okay, so that's it for the update. I need a mover and seconder to receive the MOH's update as presented. I have Alan and Brian Millen, all in favor. That is carried, thank you. Item 10 is corporate services, and we have the financial report for October 2021. And Matt, all yours.
Thank you, Madam Chair. I've presented the October financial statements. It reflects a surplus of about $748,000. Essentially, we are under budget on the human resources side. That's a combination of some of the good management that we've done and not having to utilize our resources heavily, but also incurring some additional overtime, along with some positions that we continue to recruit for. So we've got some gapping going on there. There's also some underspend in some of our programs, and that they cross a number of the expense lines. Again, because of our COVID-19 response, our programs are not completely operational, and the human resources are dedicated towards the case and contact management, vaccine delivery, et cetera. Our capital projects are on time, on budget, a little bit under budget actually. So those things are all going well. And I think that's the end of my report, and I'm open to questions.
Thanks, Matt. Any questions or comments for Matt? I see Chris and then Brian Millen. Chris?
Yes, Matt. I noticed a lot of our surplus is coming from the fact that we're a bit understaffed in several areas. And I noticed we have about 9 openings on our website. A lot of organizations that I'm with through my spot on council, we're having the same type of problems. So I just wondered if we could get a report next meeting, perhaps, on how we're making out addressing the staffing gaps at the health unit, and what the strategies are. I'd be interested, because certainly you can think of 3 other entities I'm with that are having the same problems.
Thanks, Chris. Dr. Ayres has a comment.
Thank you for the question. We are actually not understaffed. We are overstaffed. Our staff is 100, 110, depending of the summer, winter. Right now we're over 155. 2 events that took place over the past months or 4 weeks that resulted in many posting. One of them is the approval of funding for 2022, which is usually something that comes early in 2022, but the pressure from different boards of health over the past 3 months, that you've seen many correspondences that we endorsed ourselves to ensure there's funding for 2 things. One, the response to the emergency that might continue or imminently is continuing. And the second one is the recovery and the backlog, for example, in dental or vaccines that resulted from the emergency. So that approval of funding would allow us to hire more temporary positions, mainly for 1 year. The second thing that happened in the past 2 weeks is the science table news and the provincial direction that we are going to be facing a tsunami, specifically the mass immunization. So that's why you see 9 postings, but actually some of these postings are going to recruit multiple employees. There are a couple postings for nursing, and we are planning to recruit multiple. If you funnel it into a point that I wanted to mention at the end of the meeting, but I can mention it now, we have staff that have been on the go for 20 months. It is extremely difficult. I've seen cracks between people in the team and cracks within individuals, and we're doing our best with the HR help. We have a good set of initiatives to lift the morale, and one of those is to prepare proactively for the coming 6 to 9 months for people to be able to take their vacation. We need to recruit people who can do their work, and we have all the reasons to believe this is a robust plan and proactive plan, but it is not because we're understaffed.
Thank you. Follow up? No? Okay, good, thank you. Brian Millen?
Thank you, Madam Chair. And notwithstanding the significant surplus at this point, the year-to-date budget for legal is 67,000, and we blew through that by 150, almost 152,000. Matt, do you see the deficit there on that particular line item continuing, or is it going to moderate towards in the coming months?
Matt?
So I think there's, we clearly have run up against a number of legal issues through our COVID responses. I think we're now in the moderation stage. What is going to come, though, is going to come. I don't have a crystal ball on what potential other legal actions may come at us.
Darn, and I thought you had a crystal ball. Sorry.
Dr. Ayres, then Helen Claire.
I also don't have a crystal ball, but just on the first part about the deficit, we need to remember that this year, when we submitted for extraordinary funding in March, we had to factor in multiple fronts and factors that most of them have so much uncertainty, whether it's the Delta, the Omicron. So to be on the safe side, you've seen that we have put a budget that's within $1 million at the end of the year. And I see this as a reasonably good result. Some health units, if you recall, in July, August, September, ran into cash flow issues that we did not experience because we wanted to go a bit more conservative in our ask.
Thank you.
Thank you.
Okay, Helen Claire.
Yes, thank you, Madam Chair. A couple of points to make through you. First of all, kudos to the financial team, to Matt and Kim, for keeping us in the black during this difficult year. I believe that there are other health units, even though we have funding from the province, all the health units. I believe that some other health units have struggled with staying in the black. And so I just want to make sure that we acknowledge the good management that has occurred. It's also excellent to see overtime reduced, while I'm aware that we're probably going to see overtime amassing again with the increase. Hopefully it's not going to be anywhere near what we've seen historically. So I wanted to say that with regard to the financial report generally. More specifically with regard to what my colleague Brian just raised, the cost of legal. I find it ironic that the loudest attacks on the health unit have been made in the name of concern about funding. And these attacks, of course, every time there's an attack, we have to engage legal, because we are an agency, a body that we can't just make stuff up on the fly. We don't have legal assigned to us all the time. So we have to engage legal. And it's as a result of that, the increase in money that we're seeing in the budget to provide advice for us, and where necessary to defend against community or attacks that come from the community. Baseless accusations, rumors and attacks on the health unit, they affect the resources that are used and that could otherwise be used to better serve the health unit. And I think it's important that anybody listening to this recognize that any attacks that engage legal, that where we have to engage legal, affect the community that is served by public health. And those were the points I wanted to make. Thank you, Madam Chair.
Thank you, Helen Claire. Any further comments? Okay, I need a mover and seconder to receive the October 2021 financials as presented. Moved by Brian Millen, seconded by Helen Claire. All in favor? That is carried. Thank you. Item 11 on the agenda, 11.1, is the draft 2022 meeting dates for the Board of Health. And right off the bat, I would like to suggest that the January 28th meeting be moved to February 4th, as the 4 Grey County representatives will be attending a budget discussion for Grey County on January 28th. My apologies that I didn't catch that when that meeting was confirmed with Grey County, but if the board members are in agreement, we could move that to February 4th, and the rest of the dates seem to work for most people. Any discussion with that? So I think we're good with February 4th and the rest of the dates. Who's that? Oh, Brian Millen, yes.
Just as long as Santa is fully recovered by January 28th. I don't want to overdo him. I know he's going to be busy next week, but as long as he's okay with January, that's good.
Okay, I'm sure he is. Okay, so that's just for information. We don't need a motion for that. Next is review of the policies. This is 11.2, and you'll remember in January of this year, 2021, the board decided to defer policy and procedure review until later in the year. And I can say positively that we have reviewed thoroughly all of the policies, and they were available in sections on November 26th and December 6th, giving everyone time to review them. So at this time, I'll ask if there's any discussion with these policies, and I would like a motion to approve them as presented if there is no discussion. Chris?
Yes, I won't be voting in favor of the policies unless we pull the whistleblower policy. I don't feel comfortable with some of that language regarding termination. And I'd like a second legal opinion on that from a lawyer.
Okay, it is my understanding, Dr. Ayres, that policy was developed by a lawyer, but I'll let you speak to it.
Certainly. Predates me, there was a review from the ministry, and one of the items was the need for whistleblower policy. The board lawyer at the time provided that or supported or helped. I don't know the details again, but I know when I arrived, that was one of the items that the ministry identified, and it was corrected. And fast forward, there was a review of it by another lawyer related to this review, and they found it to be very robust and fair. And they introduced actually the need to include good faith. Before that, it was very open actually and encouraging to submit complaints, and it continued to be encouraging to submit complaints, encouraging to submit the complaint with the notion that there should be good faith in them. And again, two lawyers reviewed this, both of them quite experienced in the field. And I believe one of them has actually sent it to a specialist, the second one, who provided input.
Thank you.
Yeah, I know you mentioned the lawyer last time, but I'd like a second opinion, so I won't be voting for the policies.
Thank you. Helen Claire?
Yes, thank you, Madam Chair. Through you, just to underscore the fact that we as a board incurred legal fees likely to have this policy written and reviewed by a bona fide lawyer, external lawyer. So I think it's really important and prudent that we consider that with regard to the line item that was just raised about excessive legal fees in the previous discussion, whether or not this is actually really necessary to have another lawyer have a look at something that was drafted by a lawyer that specializes in this area. I'll just leave that for the board's consideration. Thank you, Madam Chair.
Thank you. Alan?
Thanks, Madam Chair. I would bring a motion forward that we adopt the policies as presented.
Thank you. A seconder? Selwyn? Okay. I'll call the question. All in favor? And opposed? That is carried.
Could I have
Thank you.
the secretary note that in the minutes, please, that I voted no?
Yes. Okay, thank you. And we have one item left, which is adjournment. But before we adjourn, I would just like to say that on behalf of the board, I want to thank staff for their commitment and dedication to see us through this pandemic. I want to share with staff that you have our support, our respect, and appreciation for all you do. So I wish all staff and their families a Merry Christmas, a wonderful holiday season, and all the best for 2022. I would also like to extend best wishes to all of this board for the work they've done over the past year, and I wish a Merry Christmas and a happy holidays to all board members. So, very good. And so, motion to adjourn at 12:54. I have Brian Millen and Brian OLeary. All in favor? That is carried. Thank you very much.
Merry Christmas, all.
Merry
Merry
everybody.
Christmas, everybody.